Um, I'm titling it Addiction and Choice. I didn't want to put addiction or is addiction a choice because I think that's too limiting. I think as we'll see, addiction and choice are inextricable. They're intertwined and cannot be separated. But the problem is in how the choice is made, how free is the choice, what is free will, what is choice, and how does it affect addiction, how does it affect how we talk about it, addicts, how does it affect what we do to try and treat them, and how we approach addiction in general. So that's addiction and choice. So the layperson most likely would describe choice as being the ability to have acted differently than we did, all other things being the same. So in any given situation, having the ability to choose is being able to take the same set of circumstances and decide to act in a different way. Also, to the layperson, free will is probably most easily defined as the ever-present sense that as we move, we are the masters of our limbs and our bodies, and we decide our route and our destination. So really, how free is our movement? Are we just moving from side to side? Do we have other options? How many options do we have? Addiction and the matter of choice comes in what model you try and use to describe addiction. The disease model says that addicts are sick, and because they're sick, they compulsively use, and at least for some addicts, that becomes an excuse to use. Of course, the moral model states that addiction is a sin, and using is a sin, and that the people who choose to use are choosing to sin, and that they have a free and simple choice as to whether to use or continue using or not. However, I think that the matter of choice when it comes to addiction is more nuanced than either of those. So if you talk about free will, it's philosophically continual debate through just about every age. There's been debate as to whether things are determined or not. If everything's predetermined, then you believe in determinism. And are people predestined to be addicts would be a great question. If you believe that genetics not only predispose you, but predestine you to be diseased, and addiction is a disease, then some people are most likely predestined to be addicts. And do humans really have free will at all? Physicists, atheists, and some philosophers tend to think that no, we don't. That if an ideal observer knew the location of every atom and electron in the universe at any given point and in time, and their speed and location, then they could predict everything that came before. I guess that's retrodiction, but anyway, and then they could predict everything that comes after. But that's the physicist's point of view. I think that certain sciences like meteorology show that knowing that and being able to predict is limited. No matter how much we seem to learn about the environment and how many sensors we're able to place, we have difficulty predicting the weather beyond a week. So, is this absolute or relative? And is it relative by degree, or is it completely relative? And is there a spectrum of free will? I'd like to argue that there is a spectrum of freedom in making choice. And in terms of the philosophy of it anyway, on the one end, there's no free will, and that's called hard determinism. Incompatibilism. There is no compatibility with having freedom. The idea that human anatomy and freedom does not exist, and moral decisions are controlled entirely by external factors. Then there's the more palatable soft determinism, in which the idea is that human freedom is limited by some external factors, but we're still partly responsible for our choices. And then at the other end of the spectrum is complete free will, and that's libertarianism. And that's the idea that humans have free will when making any decision, and that free will is not limited. I'd like to argue that addiction is a great example of how our free will is limited. It's not limited to the point that we have no control, but it's certainly not completely free either. And once again, some people equate the disease model with a fatalism for addiction, as in, what's the point of trying to resist my drug of choice because I have this disease that compels me to use it. Compatibilism says that, like I mentioned, that there's a degree of freedom of choice, but there's also some determinism. And then you can get all the way out here: libertarianism, action theory, existentialism, and the most extreme is everyone is always free and responsibility is unavoidable. The other end of the spectrum, of course, is that no one is ever free and responsibility is impossible. So when it comes to the ability to choose, it would be helpful to define willpower. And we have many common names for willpower, like determination, drive, resolve, self-discipline, self-control. But psychologists characterize willpower or self-control in more specific ways. And according to most psychological scientists, willpower is defined as the ability to delay gratification, resist short-term temptation in order to meet long-term goals, the capacity to override an unwanted thought, feeling, or impulse, the ability to employ a cool cognitive system of behavior rather than a hot emotional reaction. Conscious, effortful regulation of the self by the self. A limited resource capable of being depleted. So, I don't have time to get into the whole of the ramifications of this quote, but I would like to say that Viktor Frankl, the Austrian psychiatrist and Holocaust survivor, wrote in his extremely useful and very famous Man's Search for Meaning book that between stimulus and response there is a space, and in that space lies all our freedom. And that is so apropos to addiction, because as addicts use the cues, the craving, the stimuli that create the desire to use leads to a response. And often as the addiction progresses, the response comes more quickly and with less and less space, until when the addiction seems to be compulsion, there's no space left at all. And recovery could be characterized as working to put that space back between the stimulus and the response to allow a reasoned response rather than a habitual reflexive reaction. In the most extreme conditions of privation imaginable in the concentration camps in Germany, Frankl discovered that he was remarkably free to choose his responses to any situation. I love this quote because it sums up the essence of my philosophy. I believe it to be the cornerstone of a happy and effective life. A real experiential understanding of this radical freedom is life-changing, liberating, and empowering. To suddenly come upon the realization that we have always been free, not in some abstract sense, but in a real, personal, imminent way, is like being let out of prison. And I think that as addictions counselors, that sums up the essence of what we are trying to bring to our clients, that a real and experiential understanding through experience, we become transformed by realizing that we are free, we are liberated, we are empowered again to make rational choices rather than the insanity of the reflexive, compulsive choices that we've been making in the past. So another thing that I think helps to clarify this is that if things are, if the output is independent of the input, then it's hard to even see how things are probabilistic, but things are random, purely random. If the output is dependent on the input, things are purely determinate. As in, you could describe them with a mathematical function that would be relatively simple, like 1 addict plus 1 non-addict equals 2 addicts. If really the output depended only on the input, then things would be determinate. But given that human behavior is extremely complex, not random, but yet not determinate, it lies somewhere on the continuum between the two. And the actual mathematical study of this type of complexity is called the study of chaos, which is actually a mathematical construct instead of what most people's bedrooms look like. And it describes things as tending towards certain results, but not predestined or predetermined to end up at any of those results. So people who are who have a lot of aces, have an ACE score of 6 or more, are likely to, or much more likely to, commit suicide, end up addicted to some substance, have problems with boundaries, and thus problems with relationships that end up with them either being treated violently, being molested or raped as adults, and either perpetrating or being the victim of domestic violence. Those things are not predetermined. They're not predestined. They become much more likely. So the person's activity very distant reward of being able to fit into your swimsuit come summertime, or fit into that pair of jeans that you wanted to wear this winter or whatever. It's much more difficult to adhere to your diet because of delayed discounting. You want the reward now, and that seems more important than that long-term goal of either losing weight, maintaining your weight, or slowing your gain of weight, whatever the goal may be. And then the final one that applies directly to addiction is that there's this thing called ego depletion, which in more simple terms is self-control fatigue. Exerting your self-control reduces the amount of self-control you have left, the amount of control you have over your attention, the amount of control over and over until there's basically no space left. And at that point, I would say that they're no longer acting by the kind of free will that most of us experience. Alright, and then another thing is that there are biases, and there's this thing called delayed discounting, and that is simply to say that when it comes to dieting, if you are looking at a piece of cake, and it's the type of cake that you love, for me that would probably be a chocolate cake, and maybe it has some raspberries on it or something. Anyway, picture the cake that you love, your favorite cake. There's a piece sitting right there. You're on a diet. You know you're not supposed to eat that cake. But having the cake available, having it sit in front of you on the table, having other people around you eating that cake, makes the reward of eating that cake seem much, much greater than the very distant reward of being able to fit into your swimsuit come summertime, or fit into that pair of jeans that you wanted to wear this winter or whatever. It's much more difficult to adhere to your diet because of delayed discounting. You want the reward now, and that seems more important than that long-term goal of either losing weight, maintaining your weight, or slowing your gain of weight, whatever the goal may be. And then the final one that applies directly to addiction is that there's this thing called ego depletion, which in more simple terms is self-control fatigue. Exerting your self-control reduces the amount of self-control you have left, the amount of control you have over your attention, the amount of control you have over things that are habitual, and it reduces your ability to perform cognitively difficult tasks and resist temptation. Alright, so then I would also say that there are social limitations that apply to free will. In general, they're norms, whether injunctive or in general prescriptive. There are morals, there are ethics. Our society has laws. We have a history of things that have been achieved before and done before. And as, that's Jung. As Jung would say, there are archetypes, basically, that our society puts together roles for us, and most of us fit into those roles subconsciously. We don't even think about the fact that we're doing it. And then another limitation on our free will is language. I think it was Einstein, I'm not sure, but that said that basically if there aren't words to describe it, it's difficult to think about, it's difficult to imagine, and it's even more difficult, next to impossible, to communicate to another person. So that puts a significant limitation on what a person can learn. And then of course there are natural limitations, like when you walk out the front door you don't take off and fly because of the laws of physics. And when you want to get rich, you don't pour some chemicals together in your kitchen with a piece of aluminum and end up forming gold because of the laws of chemistry and physics, of course. And then we're limited by what we can do because of our physical bodies. They're biological, they're fantastic, but they have limitations. We can only run so fast, we can only jump so high, we can only go so long without water or food. You get the picture. So there are limitations on the individual and natural limitations, and I would say the natural limitations are pretty much absolute. The individual limitations are something that we have a little bit of control over, in that when it comes to strength, we can go to the gym to get a little more. When it comes to time, we can free some time up. When it comes to experience, we can always go and try doing things to gain more experience. When it comes to knowledge, we can go to college. When it comes to productivity, there's always ways to learn to be more productive. And as James put it, the father of psychology, that learning how to control the attention and how to place the attention back on something after being distracted is probably the best education one can get. And of course there are things that we can do to learn better habits. One of the best things you can do for your biases and prejudices for that matter, would be to just learn what they are, to become aware of them. Because by becoming aware, it's much easier to make allowances for them and understand how they change your perception of reality and how they change how you interact with other people, so that you can better make some change in what you're doing so that you're not so influenced by your biases or prejudices. And there are things that you can do to increase the amount of self-control you have available so that it doesn't wear out so easily. Now, before you flip out, this is actually a social equation used by economists to model freedom of the individual. And so I'm not going to test you on this at all. This is for the discussion, but I just wanted you to see that the limits that economists put on freedom, here's an individual's actual freedom, is equal to the maximum amount of individual freedom, which is a hypothetical, but it's then limited by natural conflict, natural individual limitations, social enforced constraints, social group achievements, social historic achievements, social moral constraints, And then group effects. So economists know that freedom is not unlimited. It's very limited by a lot of these same things that we were covering before. This is just a mathematical expression for that. I don't often endorse things put out by the APA, which, I don't know, maybe that's a bad thing. But when I found this, I guess it's one of their publications regarding what you need to know about free will or willpower or self-control, the psychology of self-control, and I was reading it. It's actually excellent. I'm going to upload it and put a link to it in the reading and other media, because this whole report basically on what is willpower and what have psychologists learned about it recently is pertinent to addiction counseling, like every bit of it. And this is taken from that report. Achieving objectives. There are 3 necessary components for achieving any objective. And I modified what they had a little bit, so it's not directly taken, but I would say that the first component is that you have to set a clear, measurable, achievable goal. So you have to set a goal. Then you have to, the next component is establishing the motivation for change. Boy, is that important when it comes to trying to convince an addict to stop using, or if they are contemplating, if they're in contemplation, trying to move them from contemplation into action. And motivational interviewing is what this is all about, is trying to help the addict see the problem and come up with a motivation by themselves to change. And then the third is exercising willpower to maintain the behaviors that lead you towards that goal. So whether your goal is to lose weight, kick an addiction, study more, spend less time on Facebook, willpower is a critical step to achieving that outcome. Willpower is a limited resource. A growing body of research shows that resisting repeated temptation takes a mental toll, and some experts liken willpower to a muscle that can get fatigued with overuse. Willpower gets more abundant by exercising restraint, and willpower gets more scarce with immediate gratification. So right there, you can see how an addict gets in the habit of immediate gratification. And I don't mean that lightly. That's like part of the core of addiction, is gratifying every want, desire, craving as much as possible, as much of the time as possible. And that's another part of why the HALT acronym is useful in recovery, because there are states that tax your willpower. When you're hungry, when you're angry, when you're lonely, when you're tired. These all reduce your ability to exert your will. So that's why we use that acronym with recovery clients or addicts, to try and help them understand that these states, along with boredom, which is a big one, all reduce willpower and make you much more apt to relapse. So this is also taken from that report by the APA on willpower and addiction. Willpower plays a role in other healthy lifestyle choices as well, including the use and abuse of tobacco, alcohol, and illicit drugs. Developing good self-control as children may prevent substance abuse problems in teenagers and adults. According to Kevin King, PhD of the University of Washington, King and colleagues explored self-control in adolescents as they progressed from grade 6 to 11. They found that adolescents who had more self-control problems in 6th grade, such as talking out of turn in class or acting without thinking, were more likely to use alcohol, tobacco, and marijuana as high school juniors. Unsurprisingly, willpower also appears to be important in curbing alcohol use, as Mark Muravin demonstrated in several studies. In one experiment, he found that social drinkers who exercised self-control in a lab setting went on to drink more alcohol in a supposed taste test than subjects who did not previously dip into their self-control stockpiles. In another study, Muravin found that on days when underage social drinkers found themselves having to exert more self-control than usual, they were more likely to violate their own self-imposed drinking limits. This finding provides more evidence that exerting willpower in one sphere can undermine your capacity to resist temptation in others, unrelated or other unrelated areas of life. Understanding the role of willpower is likely to be important for developing effective treatments for addiction and in helping guide people towards making healthy choices, such as eating well, exercising, avoiding addictive behaviors, and ending an addiction. So at this point, I'd like to turn the program over to one of the world's leading experts in addiction and choice, and that's Gene Heyman. And he wrote a book, I believe it was in 2012, called Addiction, a Disorder of Choice.
Welcome to Faculty Insight, brought to you by Harvard Extension School in partnership with ThoughtCast. I'm Jenny Attia, and I'm speaking with Jean Heyman, a research psychologist at McLean Hospital, a visiting associate professor at Boston College, and also a lecturer in psychology at Harvard Medical School and Harvard Extension School. Jean Heyman, you've recently written a book called Addiction, a Disorder of Choice. It's proven to be rather controversial. Why the controversy?
The controversy has to do, I think, with people's understanding of choice and their understanding of addiction. And for many people, and I think most of the public, those two terms don't go together. They seem contradictory.
When I think of the word addiction, it immediately makes me think of something you do not control.
Right.
You can't stop it. If you could, it wouldn't be an addiction.
Precisely. And if you look in the dictionary, addiction means against one's will. It's compulsive. And when I started reading the literature, I ended up with a very different picture of addiction than the one I started with.
How do you define addiction now, Jean?
My definition, I just take the American Psychiatric Association definition, and that is the persistence of drug use despite aversive consequences.
Jean, your choice model of addiction flies in the face of the conventional thinking, though, which is called the disease model.
Yes.
In fact, there is a genetic predisposition in some people.
Right. So there's just like there's a genetic predisposition to be a piano player, to be a baseball player. It doesn't mean you have to be. People come into the world with talents that push them in one direction or the other, or liabilities that push them in one direction or the other. We're not blank slates. We come in with all of these predispositions, and one of the predispositions influences drug use.
It seems that you're distinguishing between predisposition and predetermination.
Yes, I am, and I think that's the case for virtually all genetic influence traits. I frame the issue in terms of the nature of behavior. So then I ask the question, to what extent are psychiatric disorders influenced by things like people's opinion, by concern about employment, about concern about legal consequences, about respect from your children or your parents? And if we look at something like schizophrenia, if we look at those symptoms, we are going to see that we can't influence them by saying, well, this will embarrass your children if you're hallucinating. That won't stop someone from hallucinating. However, if we look at drug use and addicts and we ask what are the factors that influence them stopping, it turns out that one of the main things that we see is their concern about their children, what their parents think, their concern about employment. These are the factors that influence people's drug use for people who meet the criteria for addiction. So that's what I mean by choice, activities that can be influenced by costs and benefits.
What about the brain, though, being affected by drug abuse? There are changes in the brain from drug use that are not for the better.
The reason in general why drugs can change the brain, it's not because evolution was pushing, thinking about drugs in the future, but that everything changes the brain. And so the brain is this very plastic organ and everything changes it. And yes, drugs change it too. And there are two questions. Are the changes residual? That is, do they persist? And do they persist in a way that prevents the individual from responding to the consequences of their behavior? And to answer that question, we have to look at how addicts behave.
And I think one of the key points of your book, Jean Heyman, is that most addicts quit. That's not something I think that's very well known.
Right. And this was something that I certainly was not aware of. And I think most of my colleagues are not aware of. And one of the reasons I wrote the book was to inform my colleagues as well as the public. Addiction is presented as a chronic relapsing disease, and of all the psychiatric disorders, it has the highest remission rate. Every study shows that.
But of course, there are people who do not quit, and they can lose their jobs, their homes,
Precisely.
their children, even their lives. Did these people have the choice to quit also?
There are some data, and in the book I look at every study I can find on the distinction between those who quit and those who do not. And the basic factor is the presence of additional disorders, either medical, non-psychiatric medical disorders or psychiatric disorders. And that is a big difference, and I think that is what keeps most people keep using drugs and not quitting.
Last question, Jean Heyman. Why does it matter that you determine the meaning of addiction, whether it's a choice or a disease?
I think it matters in terms of how we understand each other, just person to person. I think it matters in terms of how we think about planning for treatment and policy. It has come, I think it's going to really matter a lot when we think about whether or not people who meet the criteria for addiction should be covered by health insurance to the same extent as something like diabetes or cancer.
What do you think?
Well, my impression is that we need some other category. We need a way of thinking about disorders in which the individual's own activity makes a big difference in whether or not they keep showing the symptoms. So I'm not saying that addicts do not need treatment. I think that they're often in situations where there's an intervention needed. But that doesn't mean it needs to be based on a medical model.
Great. Thank you so much, Jean,
Okay.
for your time.
Well,
I really appreciate it.
This has been fun. Thank you.
You've been watching Faculty Insight, a series of interviews brought to you by Harvard Extension School in partnership with ThoughtCast. I'm Jenny Attia. Thank you for joining us.
And I'm happy to be the occasion of free pizza. Nothing else that you'll get is that out of it. Can people in the back hear me? Can you hear me in the back? Okay. The talk, everybody knows about addiction. It's something that's in the news. We all have friends who drink too much and so on. So it's something that we have a kind of everyday understanding of. And you also have probably an everyday understanding of the fact that of recent advances in the work on the brain and what drugs do to the brain, and this has led to an account where we can understand addiction by understanding what drugs do to the brain. What I'm going to present today takes that into account, but it goes in a somewhat different direction that you may find surprising. The question that I'll be asking, as you'll see, is how do people who we call addicts actually behave? What is their behavior like? I got into addiction research about 15 or so years ago, and I said to myself, I was working for a drug company, and I said to myself, I want to do something that's useful for society, more useful than I was doing. So I went back to academia, and I was going to develop what I thought was really useful for society as an animal model of alcoholism. But I said I should start teaching a course so I know about this field, so I know how people who we call addicts and alcoholics behave, because I really knew about rats and pigeons and drugs, and I didn't really know about people we call addicts firsthand. So I began teaching a course, and I began reading literature that I never would have read. I began reading sociology and anthropology and clinical studies, and very different. I've been reading papers on receptors and how drugs work and things at a more molecular level. And I was shocked to discover that the addicts in these papers didn't behave like the addicts in the introductions to neuroscience papers or in the introduction to grant proposals. There was a big gap between how addicts behave when you looked at their actual study of behavior and the kinds of accounts that we learn about if you read the New York Times science section or in the papers actually of my colleagues. And so what I'm going to tell you really is a product of this teaching experience. Actually, another thing I should say, I went into the discipline saying what I really want to find out is how drug use changes from being voluntary to involuntary. That's the problem I set for myself. And I remember giving my very first seminar about this, and I explained to people how I'm going to find out about this process of how behavior becomes involuntary, because that's what addiction is. And what I ended up discovering is that by ordinary language criteria, we probably shouldn't call drug use in addicts involuntary, but voluntary. So that's sort of the punchline in the history behind this.
So I'd like to apologize for the poor quality on the video and audio from his presentation, but he's a little long-winded. You may think I am, but compared to me, he's really long-winded. So I'm going to take you through a little bit of his presentation more quickly than he does, because your video here would be probably an hour and a half if we listen to everything he has to say. It's very interesting, but in the interest of time, the current dogma, of course, is that, and what dogma means is the truth according to the majority of people working in the field of addiction, in this case, is that addiction is a disease. Addiction is a chronic, relapsing brain disease. These are the views of some addiction experts, both the former and current directors of NIDA, Alan Leshner and Nora Volkow. Both describe addiction as a brain disease, chronic and relapsing. Like other chronic illnesses, it involves chronic, compulsive drug seeking and using. And Nora describes it, or Dr. Volkow describes it, as compulsive drug taking and an intense drive to take drugs at the expense of life-preserving activities, so possibly even to the point of death. There's some policy recommendations by experts that he covers, the effects of drug dependence, treatment are optimized when patients remain in continuing care and monitoring without limits or restrictions on the number of days or visits covered. Wouldn't that be nice? Anyway, another person, Dr. David Gastfriend, a recent director of the Addictions Research Center in Massachusetts General Hospital, said that 10% of the population are unknowingly vulnerable to alcoholism when they drink, and they cannot be held responsible for developing that illness of alcoholism. And then Dr. P. Martin put it, I find it useful to conceptualize addiction as the cancer of behavior. How else could one fathom the mother who buys cocaine for herself instead of food for her children? So some addiction views from addicts. He refers to William Burroughs as being a counterculture icon, hero, and openly addicted to opiates. And Burroughs writes, junk yields a basic formula of evil virus. A dope fiend is a man in total need of dope. Dope fiends are sick people who cannot act other than they do. A rabid dog cannot choose but bite, from his book Naked Lunch in 1959. And then another addict he introduces the views of is this individual, Patty. She's the mother of 2 girls, a former heavy cocaine user for about 15 years, and a former drug dealer. And she put, for a time my nose opened up when I went out partying and drinking, but I learned how to handle it. You know, I never really decided to quit using, but just quit selling, and once I stopped selling, I didn't have the money to buy anymore, and I would literally have had to say, sorry girls, you don't have anything to eat this week, and so that she could actually buy more cocaine, and I would have exactly $80 for 2 weeks of food. So this is a person who quit and didn't receive any treatment, and she was a dealer as well as having a heavy 15-year habit. So, and then in a more recent than the presentation article that he wrote, he writes that do addicts have free will? Nevertheless, the question of whether addicts are compulsive drug users remains controversial. In a series of recent publications, clinicians, neuroscientists, and philosophers have simply assumed or explicitly made the argument that addicts remain voluntary drug users. It gives a number of references. Research on the biology of drug use and addiction is well known, yet the argument that addicts retain the capacity to say no to drugs has, if anything, gained more adherents in recent years. Thus, it is fair to say that today there are 2 versions of addiction. In the statements of the federal health agencies that support most addiction research, and in countless journal articles, particularly those by neuroscientists, the reader is greeted with or by the phrase, addiction is a chronic relapsing disease, and compulsive drug use, along with the implication or explicit claim that addicts want to stop using, but against their will get high anyway. In contrast, in many papers that focus on the patterns of drug use, and the key phrases are voluntary, choice, alternatives, and contingencies, much is at stake in this controversy. How addiction is classified is critical for strategies on how best to reduce the harm it causes, health policy, and what people who use drugs in excess amounts expect of themselves.
There isn't any, if you have a new idea, a new thought, it's because your brain has changed. Hopefully, at the end of this hour, your brain will be different than before, and if we knew where to look, we would see it. So here's your brain on visual cartoons. And so these are, I think people were interested if somehow visual cartoons were processed differently than verbal cartoons. And indeed, there are to some extent. But your brain is just changing all the time as a function of these of this experience, simply looking at a cartoon that has a discrepancy in it, produces change. So that your brain changes is nothing unique to drugs. That's one thing. The second thing I want us to be aware of is that a drug changes the brain doesn't mean that it has produced any functional or behavioral changes relative to that drug. We know that drugs change the brain. Do these neural adaptations alter behavior such that the individual is an involuntary drug user? And obviously, we're going to have to define voluntary and involuntary. So the question is not that do drugs change the brain, but do they change the brain in a way that alters behavior so that the individuals are no longer susceptible to those factors which influence choice? Okay, so let's look at some data. And again, so here I'm just going to orienting you, just giving you a sense about how many people take drugs, and of those people who take them, how many end up meeting the official American Psychiatric Association criteria for dependence, which is the technical word for addiction. And this I put in community studies, and I put it in heavy print because most of the research I'm going to describe was done on representative populations, on epidemiologists going out into, these are all done in the United States, creating a sample, often of tens of thousands of individuals. And the sample is selected so that it represents the demographic features of the country as a whole in terms of age, in terms of gender, in terms of ethnicity, in terms of income. And so you get a sample that's sort of like the little America in with 8,000 to 40,000 individuals, and then you interview them extensively using the you may have heard of the APA, or Diagnostic and Statistical Manual of Mental Disorders criteria for various psychiatric ailments, including addiction. And so you can get a sense of the prevalence of these disorders in the public. And the reason why people start doing this is because they realize that people who show up in the clinics may not necessarily be representative of the disorder. There may be something about people who go to the clinic who's different. And also you can't tell what is from the clinic population, you can't tell what are the percentage of individuals who are getting treatment. And there was an interest in knowing whether the percentage of individuals getting mental health treatment, whether that needed to be, effort needed to be expended to expand those percentages. So these are, these may be a little, the yellow ever used, I think are, there's reason to believe that those are slight underestimates. So we see that for cigarettes and alcohol, percentage who ever used is very large, but those who become dependent, this is a little bit out of date. Now we're closer to about 20% of the population are regular smokers. When this was done, it was about 23. Alcohol is about 12%. Other drugs, this is all other drugs together, it's about maybe 8%. And we see for different drugs, it's different. It's hard to see. But so these are the people, so always less than half of the people who experiment with a drug end up becoming dependent on it. It's very hard to see. I should have perhaps changed the axis here. But for heroin, actually, although it's hard to see, it actually has the highest prevalence, the highest percentage of those who ever try it end up becoming dependent. So that the likelihood of trying heroin becoming dependent is actually a good deal higher than it is for cocaine, marijuana, alcohol, and cigarettes. So there are drug differences. We're going to jump right away to the issue of chronicity
So anyway, my excuse for using this video is that it is the only video of him giving this presentation available on the internet. But anyway, that aside, right when he gets to the most important part, it cuts out, of course. and that is addiction a chronic disorder, as it's so often claimed? In fact, to paraphrase O'Brien and McClellan, cure is an unrealistic hope. Addiction requires lifelong treatment, as does arthritis, diabetes, and asthma. And from the textbook of clinical psychiatry, for addict patients, recovery is a never-ending process, and the term cure is avoided. And these are from community studies, as he's pointing out. So these are representative of all addicts in the community, and about 84% don't get treatment. But as I have pointed out before, and he is the source of that information, the number of addicts, he's looking at the people who've tried in their lifetime minus the number who tried or are currently using, rather, over the number who've tried the drug in their lifetime. That provides the remainder percent, or remission percent rather, my bad, and it's roughly 80% for each of these studies, each of these national surveys, this one in 90 to 92, this one in 01 to 03, and this one in 01 to 02, with approximately 2,700 drug users interviewed in detail to come up with these numbers. So indeed, addiction is not a chronic disorder for about 80% of people who use or have ever used. And then is this true of different drugs, or is this something that only holds in general? And it's actually true for marijuana, opioids, and stimulants. In fact, for marijuana, it's about 80. It's a little bit lower at about 74 for opioids, and up around almost 89% for stimulants. The reason it's lower in this EAC survey is because they were using dependence and abuse together, and the NESARC survey, they were looking at just dependence. But the high remission rates are not much different when you look at different drugs. So indeed, the result holds.
So we have a puzzle. Addiction is usually not a chronic disorder. In fact, if you look, I've done these calculations for every psychiatric disorder, and it's in a category of its own. The recovery rates for addiction are by themselves, and for the other psychiatric disorders that are in the DSM, they're much, much lower. It has the highest remission rate of any psychiatric disorder that has been studied. And so we can ask why experts, clinicians, National Institute of Drug Abuse call it a chronic relapsing disorder. Where does that come from? You know, it's hard to imagine that it's just sort of made up. It must come from somewhere. And we can find out. The next slide will show us where that idea comes from. Let's recall that the data that I've been summarizing here are based on research projects where they initially try to get a representative population and then find those individuals in that population, it's very large, who meet the criteria for addiction. That's very hard to do, that kind of research. You have to interview thousands and thousands of people, because even though addiction is perhaps the first or second most prevalent psychiatric disorder, it is still, you're only getting 4 or 5%. What most researchers do in psychiatry is they study people who show up at their clinics. It's much easier. I've done both rat research and human research, and it's much easier doing rat research. The rats always show up. The people don't. They call you up. If they even call you up and say, I slept late. You are familiar with those excuses, and so on. So it's very hard to do that kind of research. So people typically study those people who show up at the clinic. And when you look at relapse rates, this is the people who come to your clinic. Relapse is perhaps more appropriate for looking at clinic populations. You look, these are people who have stopped taking drugs, at least while they're in the clinic, or at least cut down a great deal, and then you keep track of them afterwards. And what you discover is those people in the clinics typically start using again within 6 months to a year. Just the opposite of what you see in the general population. Here, this is a really interesting comparison. These are a very 6% of the Vietnam veterans ended up going to clinics. They all could have gone to VA hospitals for their drug issues, but only 6% did. Of those 6% who did, this is their relapse rate. It looks just like the domestic addicts, and the mirror image, the converse of what you see in the general population of addicts. So the question becomes, obviously, this suggests maybe there are two kinds of addicts, or at least what is, a critical question becomes, what is the difference between clinic and non-clinic addicts? That will tell us a lot about addiction, at least as it's understood. And surprisingly, this is not a very widely researched topic, and it's not widely researched primarily because these results are not familiar to people. I mean, they're becoming more familiar now. But people were not aware of this incredible discrepancy between the clinic data and the data based on randomly selected populations, on representative populations. So there's something about the people in the clinic that's different. And what we know for sure is the following. What is different is that individuals in the clinic, if you look at other psychiatric disorders, not addiction, but you look at depression, OCD, conduct disorder, they are more than twice as likely to also meet the criteria for these additional psychiatric disorders. They're a very different population as measured by mental health. In fact, if you look at the people who meet the criteria, all these people meet the criteria. Everybody, dark green in these different grays, all meet the criteria for addiction. These people did not seek treatment, and they're really not much different than those individuals who were not drug dependent in terms of the overall rates of psychiatric disorders. However, those who end up in the clinic are very different. And I think this actually underestimates the difference in what people call comorbidity. I volunteered at a methadone clinic, and one of the things that struck me was not only was there a very high rate, virtually everyone had some psychiatric disorder, but there was a very high rate of non-psychiatric medical disorders, extremely high. So that in addition to these psychiatric disorders, there are big differences in non-psychiatric medical disorders. So the population of people who have been informing expert opinion about the nature of addiction not only suffer from addiction, but they suffer from a host of other disorders. My hunch is that it's very, and we can ask the question, why does that matter? And maybe we'll briefly have a chance to say something about it, but it clearly makes a big, big difference. And there may be other issues about what happens in clinics that maybe are prevention enhanced. It's possible. But in any case, this is the one. You also might ask questions about whether there are differences in the pharmacological history as well. Maybe these disorders are a function of taking drugs more. I have tried to track that down. Again, there's very little research, but that, in the few studies where you can look at people in terms of their age and their drug history, it turns out that we don't see a difference there, but we do. This always pops out in the psychiatric history. So a pharmacological history has yet to emerge, but again, this hasn't been widely studied. So we can summarize where we are up to now. Okay, so is addiction a chronic disorder? No. In representative populations, most people quit by their late 20s, early 30s. In clinic samples, not all, but most, addiction persists. But implicit in this is that most addicts do not go to treatment. So not only are the clinic samples not representative in terms of their remission rates, they're not representative numerically. Most addicts, most individuals who meet the criteria of addiction do not go to treatment. And so our understanding of addiction comes from a non-representative group numerically and a non-representative group in terms of their additional medical and psychiatric disorders. Okay. How do we define compulsive, how do we define choice, how do we define voluntary? And this is how I approach that question. I say, what are the kinds of factors that influence decisions, influence choices? Are those the kinds of things that influence drug use in people who meet the criteria for addiction that we just identified? And so what influences decisions, information, values, what other people think of you, costs and benefits, those are the kind of things. And this is sort of built in. This isn't really my definition, it's really society's definition. If you notice, in Boston, and I'm sure here, there was a flu scare, I guess 2 years ago, and all over institutions and schools and public places, there were signs, wash your hands. And they had little things. There were no signs saying, don't sneeze. Nobody puts up a sign saying, don't sneeze. But they do say, don't wash your hands. Why? Well, because sneezing we think of sneezing as kind of an activity that isn't influenced by information, by consequences, and so on. But washing your hands is. So that's what I'm getting at, that distinction. Or I once belonged to a gym where they said, don't spit on the floor. Because people did spit on the floor all the time until they put that sign up. But they didn't say don't sneeze. And so on. So we are aware of that's what I'm asking. So I'm asking if people who meet the criteria for addiction, if you provide consequences for their behavior, will it change? And we can immediately answer that, at least logically, by what we've learned about the epidemiological data. And we saw that most of these people quit by age 30. They quit without any intervention. So what leads them to quit? Well, I think just reason tells us that what lead them to quit are other things going on in their lives. What is going on in their lives? Well, it's one thing. It's perhaps not as fun to take drugs anymore. As you get, you'll discover that. The other thing is that people start having families. They begin worrying about careers, about having a job. Life begins to catch up to you when you're 30, and So if it isn't an intervention, these must be the things that are playing a role, and these are the things that affect our choices. So we can, that again, that's reason and inference, so we can check that. There are ways that we can check this, and I'll just give you one study. Maybe I don't know if you've had this course, but there are treatment programs now for addiction that actually take, at least implicitly, the kind of data I'm describing to you, take it to heart, and they organize treatment around it. So here's a program where people got incentives. They're people who met the criteria for cocaine addiction. They were interested in treatment, though, which is unusual, as we've learned. And they came to the treatment, and what they got were incentives that they could, sort of coupons, vouchers that they could trade in for things like taking a cooking class or sports equipment, these very pro-social activities, activities that would have perhaps have some kind of inertia to them, so after you did them, you might become more interested in them. And on the x-axis, it was a 12-week treatment program. On the y-axis are those who are continuously abstinent. This is a very strict criteria. As soon as you test positive, they get tested 2 or 3 times a week. As soon as you test positive for a drug, you're off of this graph. And these are the people who had the incentives. These are the people who had a regular counseling. And we see that the incentives made a big difference, that they're continuously absent. Of course, most of them have resumed drug use, but this may mean they've only used the drug once, or it could mean they're using every day. We can't tell from this graph. But then they did a follow-up study, and in the follow-up study, they've been offered for 3 months, 6 months, 9 months, and 12 months. They've been away from treatment. And we're looking at cocaine abstinent. They get tested when they come back in. And what's interesting to me about this is that the abstinence rates are actually increasing over time, and which suggests that these pro-social programs are effective. And what I think they're doing is providing alternatives to the drug use that people find valuable. They end up choosing them themselves and so on. Okay, so if time is running out, the other thing that, and I'm going to, I'll say just one thing about why people end up getting involved in this activity that's self-destructive but voluntary. The other thing that we learn about quitting drugs is that people are often influenced by moral concerns and familial concerns. So the kinds of things that are the correlates of quitting are consequences, concrete costs and benefits, and basically people's values and their attitudes towards family and family responsibility. Okay, so summary. In most representative samples, most addicts quit. They do so without formal treatment. The correlates of quitting are the correlates of choice. The correlates of not quitting are psychiatric disorders. We don't know about that. There is a punchline, too, so you guys leaving, you don't get it. The natural history of addiction is very different if we use representative populations. That's one example, one thing you should go away thinking. And addiction is a much more viable
condition than traditional chronic illness. And of course, the video conked out again right at the very end. But anyway, so the conclusions: the natural history of addiction that includes non-clinic or community populations varies markedly from the addiction in the chronic disease model. Drug use in addicts is more susceptible to change than suggested by the often heard addiction is a chronic relapsing disease expression. And if natural recovery is a proper model for treatment, which I don't know if it is, especially in a dual diagnosis population, but if you're dealing with people without a psychiatric or medical complication or illness, it probably is. and treatment should emphasize non-drug alternatives like engaging family, a pet, especially a dog, school and or work, new peer group, and a new support group. And I'm not necessarily suggesting that one take on a new pet or relationship early in recovery. I'm just saying that these should be presented as eventualities to people who are trying to get off drugs, and long-term treatment of people with a dual diagnosis should include these things, potentially after maybe 6 months or even a year of treatment, if there's any ability to continue to engage the family and the patient or the client, to encourage them to pursue school or work, and to continue to try and engage them in a peer support group like AA or NA, or even just something that continues at the treatment facility. But anyway, thank you for your attention and time, and enjoy the discussion.